So welcome to the last episode, the Insulin Transition, part 6 of the Inpatient Hyperglycemia from Crisis to Control. Now, I'd like to begin with this slide, the multiple transition with shifting clinical situation during hospitalization. Okay, for patients with diabetes, a single hospitalization may involve multiple transition. Each transition may require specific insulin regimens. Patient may be treated at the emergency room or admitted to the ward or to the ICU or proceed directly to surgery. They may then receive different levels of care with overlapping or sequential interventions such as MPO, status, enteral nutrition by tube feeding, or total parenteral nutrition, medication such as steroids that may worsen glycemic control and dialysis. Patient transition back to an outpatient setting either directly to their home or an intermediate setting such as rehabilitations or skilled nursing facility. With this, the clinical situation may shift frequently with numerous opportunities for breakdowns in communication among teams and various care providers at any given levels. So in this episode, we'll explore key insulin transition across the care journey. We'll begin with how insulin therapy is adjusted upon hospital admission. Then we'll cover transition within the hospital such as shifting from IV to subcutaneous insulin and managing perioperative changes. Finally, we'll discuss how to safely transition insulin therapy from hospital to home. Now, transition from home to hospital. Okay, insulin therapy is preferred method for achieving glycemic control in hospitalized patients with hyperglycemia. Discontinuation of oral hypoglycemic agents is recommended, and initiation of insulin therapy is the one that is recommended for majority of patients with type 2 DM at the time of hospitalization admission for acute illness. And finally, patients treated with insulin before admission should have their insulin dose modified according to clinical status as a way of reducing the risk for hypoglycemia and hyperglycemia also. So let's go now to safe and effective transition of inpatient with hyperglycemia. Let's start with perioperative transition in diabetes care. Now, managing diabetes around surgery requires careful insulin adjustment. Before surgery, hold oral agents and reduce basal insulin to prevent hypoglycemia. Now, during surgery, IV insulin is preferred for major procedure, but this will depend on blood glucose level control of patient before the surgery, with glucose monitoring every 1 or 2 hours. Now, after surgery, resume insulin based on nutrition, stability, overlap basal insulin before stopping IV, and add prandial and correctional doses if the patient is eating. Clear communication across teams is key to safe glycemic control. The key reminder here is clear communication across surgical, anesthesia, and endocrine team is essential to prevent complication. Now, when switching from IV insulin to subcutaneous insulin, timing and stability are the key. First, confirm that the patient is clinically stable, for example, with resolved acidosis in DKA or improved hydration in HSS, and that they are able to eat or expected to eat soon. The next is calculate the total daily insulin dose if the IV insulin drip has been running for 24 hours or more, so we can use 60 to 80% of the total IV given over that period of time. But if the drip has been shorter, say just 6 hours, you can extrapolate based on the infusion rate. For example, a 50 kilogram patient receiving 0.1 units per kilogram will get about 5 units per hour or 30 units over 6 hours. You extrapolate to 24 hours, that's about 120 units, and 60 to 80% of that given a safe total daily dose ranging from 72 to 96 units. So 50% of that may represent the basal, and if the patient is eating, 50% will be for bolus or prandial. Always adjust based on clinical context, insulin sensitivity, and nutritional status, and monitor patient for blood glucose. Before stopping the IV infusion, administer a long-acting basal insulin such as glargine or determine 1 to 2 hours in advance. This overlap ensures continuous insulin coverage and previous rebound hyperglycemia. If the patient is eating, initiate mealtime or prandial insulin and provide correctional dose based on the bedside glucose level. And finally, monitor glucose closely every 4 to 6 hours and adjust the regimen as needed. Now, each step ensures a safe, smooth transition from crisis to control. Now we go now to transition from hospital to home. Now, resume pre-admission diabetes regimen at the time of discharge for patients with acceptable pre-admission glycemic control and no contraindication to prior therapy. Modify pre-admission therapy for patients identified as being in poor control. And finally, provide patient and family members, caregivers, with written or oral instruction regarding glycemic management regimen at time of hospital discharge. So, when patient improve and ready to go home, the question now is what regimen should we use? What's the recommendation or what is the advice? Now, this is from the study of Umperes et al., the management of patients with diabetes after hospital discharge. So, inpatient management in non-ICU, either basal bolus or basal plus regimen. So, what then, if the patient improve, what regimen should we use at hospital discharge? So, what's the approach? If the admission A1C is below 7%, the patient can usually continue their pre-hospital regimen. However, if the A1C is between 7 to 9%, it's recommended to discharge with basal insulin in the regimen even if they weren't previously on it. Always base discharge planning on the admission HbA1c as it reflects the pre-hospital glycemic control. So this is the discharge insulin algorithm that study based on the admission A1C, and this approach comes from the study entitled Hospital Discharge Algorithm based on admission HbA1c for the management of patients with type 2 DM. Its goal is to provide practical evidence-based guidance for managing diabetes at discharge in general medicine and surgical patients. The key takeaway is measuring A1C at admission help personalize insulin therapy at discharge, improving safety and glycemic control. In this algorithm, if the A1C is less than 7% on admission, so you discharge the patient. You may restart outpatient treatment regimen, OAD, and or insulin. If the A1C is 7 to 9%, restart outpatient oral agent and discharge on glargine once daily at 50% of hospital dose. And if the A1C is greater than 9%, you discontinue or discharge the patient on basal bolus at the same hospital dose. Alternatively, restart oral agent and discharge on glargine once daily at 80% of hospital dose. Now, using this algorithm, the study results shows change in A1C concentration at 4 weeks and 12 weeks after hospital discharge. There was significant improvement. Now, the primary outcome of the study is change in A1C at 4 and 12 weeks after discharge. When you look at the data, A1C on admission was 8.67 plus and minus 2.5%, and it decreased to 7.86 plus and minus 1.7% at 4 weeks, and at 12 weeks, it was 7.26 plus and minus 1.48%. of follow-up. Now, all of them are statistically significant. However, they show an increased rate of hypoglycemia, but about 30 to 40%. And because of the increased rate of hypoglycemia, they revised the algorithm with the A1C of less than 8% instead of less than 7% to restart outpatient treatment regimen. For the previously 7 to 9%, it became 8 to 10%, and for the above 9% A1C, it became more than 10%. And with that, this marked the final chapter of our series, and thank you for joining me throughout this series.